Hello, everyone. Welcome back from lunch. We were going to get started with our afternoon session, and Julie Rios is going to be the moderator for the afternoon, but I'm just going to be the moderator for this next panel discussion. I'm Erin Rowell from Lurie Children's Northwestern in Chicago, and our discussion now is going to be an ethics discussion. Maybe we could get our first slide up, if we could. And so the focus of this is fertility preservation in patients with poor prognosis. This topic really was of interest to me a few years ago in a discussion with one of our oncologists about pediatric patients, particularly really young children that have serious diagnoses, in particular brain tumors, where we really don't expect those children to survive, and whether it was ethical to talk to those families about fertility or not. And I have had that kind of germinating in my mind and had mentioned it to Monica in the planning for this. And then I know Julie also got really interested as far as poor reproductive prognosis. So that's those kind of two main groups are the focus of this, and I'm going to introduce our panelists. And the first one is Dr. Julie Rios. She recently joined the faculty at the University of Pittsburgh Medical Center as the Division Director of Reproductive Endocrinology and Infertility, and she's the clinical lead for the Center for Reproduction and Transplantation. Her research interest is in ovarian aging, optimizing infertility outcomes, and fertility preservation. And a fun fact about Julie is that she has IUI twins who are almost 6 years old with frozen oocytes still being stored. So that information she provided to me, that's okay for you to know, because it just highlights how important these discussions are. All right, next is Dr. Jennifer Levine. She's an associate professor of clinical pediatrics in the Division of Oncology at Weill Cornell Medical Center. She treats patients with leukemia and lymphoma, runs the long-term follow-up clinic, and her research interest is fertility preservation in pediatrics. And a fun fact about Jennifer is that she had successful IVF 1 month shy of her 44th birthday and now has a healthy 10-year-old son. All right, and Dr. Joe Bertino is the Director of Ethics at UPMC Presbyterian, Shadyside, and Western Psychiatric Hospitals here in Pittsburgh. Prior to arriving at UPMC, Dr. Bertino worked as a clinical ethicist for WellStar Health System in Atlanta and held clinical and visiting faculty positions at Georgia State University and the Philadelphia College of Osteopathic Medicine. He is a nationally certified clinical ethicist and author of the recently published book, Clinical Ethics for Consultation Practice. I don't have any fun facts about you, Joe. I'm sorry.
I just adopted a 3-month-old puppy, so that's kind of fun.
Perfect. Okay, so without further ado, let me figure out how to advance here. Okay, there we go. So our discussion point is, should a patient with poor prognosis from a reproductive potential standpoint or oncology diagnosis undergo fertility preservation counseling and or be offered fertility preservation treatments? So, case one, a 40-year-old G0P0 female was recently diagnosed with ER/PR positive breast cancer with a plan to undergo surgery followed by chemotherapy. Should this patient be referred for fertility preservation counseling? This patient, a little bit more information. This patient opts to meet with an REI to discuss fertility preservation. She is not in a relationship and is not interested in using donor sperm at this time. You can see the initial lab tests showed an antral follicle count of 3, AMH of 0.2, and FSH of 13. And this was her prediction of prognosis based on the fertility risk calculator. So this is our basic information about case number 1, a case of poor reproductive prognosis, and I'm gonna let Julie say a few words about that.
So I think this is a common theme that can come up when patients are being referred to the REI for egg freezing of, oh, well, they're already 40. Do you even offer egg freezing? Should we even counsel that patient? And so I brought this case up just to kind of look at it from the ethical perspective and all the things that we will consider with the patient. And I think it's common of whether they're referred and then whether should we even offer the, egg freezing procedures. And we'll talk more about it as we go through.
Okay. All right, case 2 is a 3-year-old boy with newly diagnosed diffuse intrapontine glioma, or DIPG, brain tumor, with a plan for debulking surgery and then a second surgery for central venous access and imaging under anesthesia. Should the patient and family be referred for fertility preservation counseling? Jennifer.
So I think some of the things that are interesting in particular about this case is, first, of course, that it's a young child, young enough that the patient himself can't provide consent, but also cannot provide assent. The prognosis for DIPG is really pretty terrible, and even among pediatric oncologists is kind of, one of the sort of biggest concerns in terms of outcomes, so certainly very extreme in terms of prognosis. The option in terms of an intervention itself is experimental, and the intervention for treatment itself does not necessarily impact long-term fertility potential, and so I think this kind of a case really pushes the question of how much sort of parent and family autonomy exists in terms of what patients can say, where you fall in terms of saying, I understand the risks, but this is my desire, because it's the poor prognosis oncologically, but not necessarily in terms of reproductive potential.
Great. Okay. We're going to move into a couple of ethics slides, so I'm going to turn it over to Joe for that.
Hi, can everyone hear me? Yeah. So I think a lot of this might be familiar to a lot of you, if not all of you, but when we're looking at cases like these, we have to have some kind of objective structure to place all the information and to really consider what we're dealing with. So when we talk about ethics, or just what we're doing in a clinical space with ethics or vocational ethics, the question is, what are we seeking? What are we looking to accomplish? Is it truly a reasonable endeavor, or is it because it's so aspirational we shouldn't even try? Well, that's what ethics is. It's aspirational. You're not going to get it right, but you are going to get it as right as you can. And that is the point of pursuing vocational ethics in these cases, what we're looking to do, right? What would you want to have done in this situation? The golden rule still stands, and no, it's not whoever has the most gold rules. It's do unto others as you would have them do unto you, right? It's a very real message that surrounds these foundational principles of ethics that we'll talk about. Next slide, yeah, that's good. So these ethical obligations, I think, excuse me, many of you know these as the principles of bioethics, right? These are 4 foundational principles, and that's great. I think they all serve a wonderful purpose. I think they are extremely relevant to just about every ethical situation you can come across. But how do you apply this? How does this actually go into the clinical space in a manner where we can really come to a solution or some kind of resolution with potential conflict or a situation amongst care team members, clinical members that say, should we do this? We can. Should we do this? So a brief rundown of these, right? Beneficence, we're looking to do good, right? Do good for our patients, do good for anyone that really needs our expertise or our specialty. Non-maleficence, do no harm, pretty obvious in that respect. Autonomy, this is the big one that we always talk about. What really is it? Do we have it? Who doesn't have autonomy, right? Does a child possess autonomy, and when, if at all? Finally, justice, right? Making sure that we fulfill our fiduciary duty to others. We're really making sure that we can provide equal care to everyone. And I know these concepts are pretty common. What's not as common, some of you might know this, is how we apply these principles to these really complex cases and questions. Next slide. So for Johnson, Sagler, and Winslet in their text, they actually come across this 4 topics, 4-box approach. Many of you may have covered this in a bioethics class and whatnot, but what these 4 pieces really do is assess these 4 principles of bioethics in a very comprehensible manner, right? The medical indications, what are we ultimately looking for? What has the medicine shown us that actually provokes these questions or these dilemmas? What is the actual situation itself, and how does it influence the values of the individuals involved? The patient preferences. For an adult, you can usually extrapolate these, right? We can have good conversations. Those of you who work in palliative medicine have good palliative teams, right? There are ways that we can talk about the overall preferences of the individual or find out what is valuable to them. Now, naturally, when we're dealing with a minor or someone younger, we don't necessarily have the ability to obtain what is important to them, right? They really haven't developed enough to know these pieces. I'll talk about that in a moment when it comes to these standards of decision making, how we can deviate. Quality of life I'll talk about in another slide too. I think it's so broad and people talk about quality of life and throw that around quite a bit. I want us all to think about it algorithmically. If we see it as a formula in a way that we can actually process and deliberate and communicate with our patients, it can open up doorways to those considerations for everyone involved, even those individuals who can't speak for themselves. And finally, the contextual features. What's going on? Who's involved? Who are the surrogates? I can't tell you how many times I've come across a case where it's like, hi, I'm this patient's spouse, and then 3 other people show up. We're the spouse of this patient. Like, this patient's been busy. So I have to find out who's really involved and who's discussing this. Those contextual features matter, because although the law might dictate what is what is legally supportable, it doesn't mean it's always ethically supportable and vice versa. But we have to follow the law, right? That is mandatory in our practice. We follow the law, we find out what those contextual features are, but we try to get everyone to the table who has a stake in the decision. So, like I said, quality of life, I want you to think about it like an algorithmic function. Think of it like external quality and internal quality. External being the patient's perceived quality of life, whatever that looks like. Internal quality, what is the objective standard that we might determine is acceptable or not acceptable for a human being? Now, I think a lot of us could argue and come back and say, well, it really depends on the person. Someone might identify as somebody that doesn't have functioning legs, and we should amputate those legs for that person. No, right? We don't want to harm our individuals. It's a matter of balancing those 4 principles when we're determining what is an appropriate quality of life for an individual. So when you're assessing someone's quality of life, it is, I think, helpful to present this idea of internal and external, right? This internal quality of life, it seems that you really desire X, Y, and Z. We want to try to hit those goals for you. From this external perspective, your child may never have consciousness again, right? And that is just an objective fact of the quality associated with the contextual feature. And finally, like I said, I wanted to talk about this difference in decision making when it comes to those who can speak for themselves, can really present their values in a comprehensible way, right? They have the capacity to do so. These are adults, mature minors. We're going to use substitutive judgment in those instances when they can't communicate for themselves, or if they're able to express it, great, we know what it is. But when we don't know what that is and that person has articulated it one way or another, we have to substitute whoever's judgment is in that moment. Meaning, the surrogate of that individual truly has to speak from a standpoint of the patient or the person that's involved. If we're dealing with a best interest standard, usually it's a patient who has never been able to formulate any kind of previous value, right? Infants or those who are severely cognitively impaired, what have you. These are individuals who we have to make a decision for from a clinical and surrogate standpoint of saying, what in most cases would this human being find acceptable? Right? This general blanket statement of what they would find acceptable. Clean, safe, relatively healthy, right? Can do things on their own, depending. Right? All those pieces matter when you're determining a best interest standard for that individual. Finally, I believe this is my last slide. Ways that you can prep for this kind of situation. Now, naturally, this isn't a conversation or a consideration that a lot of parents are probably having with their newborn, right? Or considering about their newborn when it comes to preservation. They can't really participate. But what if we were to think about these questions more? What if we were to present this in a manner that actually had people think about, well, what would we do in this scenario? Maybe we have some clinical information, some context that can help prepare individuals to think through these questions. Individuals who might have a high-risk job, right? People who are in harm's way, adults who can actually speak to what they want to do when it comes to fertility preservation outside of just their work, right? We're talking about someone who has a diagnosis that is quite terminal and could radically affect their reproductive capabilities. So in those moments, when are we having these conversations? Everyone says, oh, we have it in the outpatient space. It's one of the best ways to hit people with advanced care planning. I totally agree. Talk about it like it's not an iffy topic. Talk about it like it is just commonplace. I think that's really going to get more people to the table and thinking about those advanced issues.
Okay, great. Thanks so much. We're going to move now to an ethical discussion of case 1, and so I'm going to turn again to Dr. Julie Rios for that.
So I'm going to just kind of review how I discuss this with the patient, and then I would love to hear other colleagues that do this and how your approach might differ from mine. But essentially, I'm a very data-driven person. We have some calculators. They're not perfect, but there are some good online tools for IVF prediction as well as success with oocyte freezing. And I use these just as a guide to discuss with the patient. So in that first slide, you saw like a 7% risk. I mean, that was basically saying, I think we're going to get 4 eggs, and you're 40, so this is your success rate. And then, some people look at that success rate and they're like, oh my gosh, I have such a great chance. And other patients will look at it and say, like, that's just too low for me. And so I think that's where you start with your shared decision making with the patient. You let them know the risks of the procedures. So that's always something we take, into account. Does the procedural risk outweigh like the risk or the chance of successful live birth? And again, it's a discussion I have with the patient saying, right now your risk of complication from the procedure is higher than your actual success rate. So it's not my recommendation that you proceed with this. However, I think it's still a discussion. In addition, I also talk about the financial cost of oocyte freezing as well as future use of those, and what's long-term prognosis. So sometimes we know we have donor gametes as an option for patients, and although that's not the ideal option, I think we really do have to talk about that elephant in the room of the cost, because if someone uses their whole life savings to freeze eggs, they thaw them out, they make embryos, they get 1 embryo and it doesn't implant, right? Because at 40, she has like a 70-80% chance that that's abnormal. Did she waste all her money on her ability to reproduce? And maybe she would have considered donor oocyte, but now she doesn't have the cost for it. So that is something, and my fellows in the room, and they hear me say this sometimes, is, if this is what you want to do, just think about if it doesn't work. Are you financially at a place to do donor oocyte in the future if that's something you want to do? Or adoption. I think a lot of people say, I'll just adopt. It's not as easy. We all know that in the room. It's not as easy as everyone says. And so really letting them know, like, adoption also has very expensive costs and very hard road challenges in front of them. And then I also think talking with the oncologist and the treatment physician, is there really any risk, in delaying her treatment or the patient's treatment to do this? Are there any medical concerns that we have? And so I think for this patient, from a medical standpoint, the procedural risk is low. Most patients with breast cancer do have the time to proceed with ovarian hyperstimulation and egg retrieval. But again, there are some cases that can we access the ovary? We sometimes have had large fibroids where it's really difficult in these cases. And so I think the disappointment that can also happen when the success is not high is really, there's a lot of anger sometimes. And so I think making sure that patients are truly aware of what their success could be. So that's my take on a challenging reproductive case. This is just particularly a patient of age to do oocyte freezing, but I've had Turner's patients too that want to do ovarian tissue cryopreservation with very low AMH tests, and that went through a discussion with our ethical team. And I think it's great that we, at both institutions I've been at, I've always had access to an amazing ethics group. And so if I do have these questions of should we offer this and what should we be thinking, how should we be counseling, I think it is a huge tool that everyone should have on their team.
Wonderful. Okay, so quick show of hands. No one's taking any stats on this. Who would have a discussion with this patient about options for her reproductive future? Okay, huge numbers of people, great. And who, if she wanted to have ovarian hyperstimulation and oocyte retrieval, who would do it? Okay, great. For those of you who can't see, I see, smattering, a fair number of hands. Okay, great. So I think we want to open this up for some discussion before we're going to do kind of a similar ethics discussion for the second case, but we'll stop with this one. Yes, hi, Rebecca.
Yeah, hi, Rebecca Flick from Cleveland. Just one quick point, I think, to add to what Julie said, which was terrific. These calculators that we all use, and there are so many pediatrics people in the room, are for one round of cryopreservation. So many of us are now doing duostim protocols, basically back-to-back protocols where you stimulate them, then after ovulation you can actually just start stimulating again 5 days later. So these are great for our cancer patients who have a limited window. And so when you're thinking about a 5 to 7% chance of live birth, perhaps we can actually make that look a little bit better using some of these newer, more innovative protocols. So I would just put that out there. And then, as with everything in fertility, age is everything. We have a lot of these young patients with low AMH, but a low AMH in a young patient is very poorly predictive of how those oocytes will perform later. So just a couple things to add to the discussion.
Great, thank you. Yes, Haquin.
Hi, thanks you guys. This makes for a really interesting discussion. I'm wondering, to what extent do you think, and I'm not sure this is the right way to characterize it, but conscientious objection could come into play in that you've outlined to the parents or to the patient what's possible, what's not possible. They still say they want to pursue it. It's not what you agree with. To what extent do you think you have an obligation to refer them to another provider who may do what they want?
I mean, I think that for me, if there is a case where I don't feel comfortable proceeding, I always do offer a second opinion. Do I always know of someone that might differ from my opinion? I don't, but I will provide those resources if that comes up. I'm a fairly liberal person when it comes to, so it's mainly if I'm going to put the patient's safety, that there's a risk of really causing medical harm to them, then I think that's for me the piece that kind of overrides that autonomy piece, is that I still have to try to do what I think is best long-term for the patient. So that's kind of my guidance, and I think there's pretty rare cases for, ovarian hyperstimulation and egg freezing that put us in that range, but there are some, and we have encountered them. Jen?
Conscientious objection is a really tricky topic, just all the way around, even with vaccinations and everything across the board. I mean, there are individuals who might conscientiously object to a certain procedure, what have you. Typically, if someone discloses that in advance, it is so much smoother of a process because we can really avoid those situations as they come up. Something you could talk to your ethics team about, or your ethics committee about, for sure, because there should be, if there's not a policy existing in your institution, there should be some piece of conscientious objection information that shows the process that you can apply for, or any individual who wanted to object to a certain specific job or task.
Okay, I want to ask a follow-up question to that. Let's take this case where you gave the patient the likely outcome of the low chance of live birth, and without ever even really talking about her own diagnosis and her own prognosis, if the patient were to say to you, regardless of the outcomes that happens to me, I plan to gift these eggs to someone else in my family, would that change the counsel? Would that change the extent that you would get involved in the case?
Let me hear what Joe has to say first.
So ownership is a really interesting topic too, right? I've had patients who have had limbs amputated and they really wanted to take them home. And the short answer is, depending on where you are, it's possible, right? You can do this. But when it comes to genetic material, when it comes to reproductive material, there's not full disclosure, I'm not an attorney. I'm an ethicist. To my mother's dismay, I'm a philosopher. But what I will say is, when it comes to ownership of those pieces, every case that I've come across in the literature, the material has been granted to the person asking for it. So in most of those cases, I could see where somebody would ask for it and then they would receive that material. But the problem is, we haven't encountered a case that's been well known or published or what have you, where there's been serious contention between two stakeholders fighting for genetic material necessarily, right? So in that case, it gets a little tougher. Typically, if a patient is relinquishing something or indicates that they're willing to have this pass on to this person, or that person truly is their next of kin, right, by the hierarchy wherever they are, usually they have a claim to that material. So it gets more and more complicated with different pieces of the body, but ownership is a big topic in ethics right now, especially. I really encourage you to look up post-mortem gamete retrieval situations and whatnot, because ownership does go to people involved.
So just I'm going to set the question, and then Joe, I think, also to answer further, but since obviously there are aspects of this that are relevant to the case of the child. Also, in that instance, what presumably would be, testicular tissue would be retrieved. And then, again, the question becomes the parents as kind of the owner of that at the time of the extraction. And then the child does not have the opportunity, presumably, if they are not going to live through their cancer diagnosis, to make the decision about, what should happen to their tissue. And of course, in pediatrics, we face issues of when you turn 18, if you're, to changing whose sort of ownership it belongs to. But, in a 3-year-old, in this particular scenario, that wouldn't be the case. So I think that, that's that's, I think, an added level in terms of a pediatric patient of that age is, whose ownership is it, and is that sustained with the parents? Any thoughts? But I think that's a big, that's obviously a big issue in pediatrics. And there's certainly, I can't speak 100% to the answer, but I've certainly had conversations where individuals, less so with either ovarian or testicular tissue, but with sperm, where there's an interest in, having someone else use the sperm, not with the patient themselves making that decision. Most sperm banks, I think, that we're, involved with there are contracts about how, who gets to say and at what different point. But again, if the person isn't of majority at the time that they die, I think sometimes, that can still be a discussion.
Okay, I think we'll go on to discussion of case number 2. Is that okay with all of you? Okay, so case number 2, I'm going to let Dr. Jennifer Levine discuss.
Yeah, so I think, this obviously provides this case a very different side of the issue. And in thinking about this, the discussion on the patient panel yesterday, I think we all, in kind of listening to the idea of fertility preservation really representing an idea of hope. And I think that what Alyssa was saying yesterday was really, if you are offering this to me, or allowing me to pursue this, what they took it as was meaning you have hope for my child. And so, I think that's just one part of this, is in a patient who has, a really poor prognosis, what is that balance? And, we talk about this on the palliative care side of things, is how do you balance hope, and what does hope mean? And maybe hope, in many ways, hope doesn't always relate to living. But in the case of fertility preservation, it is linked to, the anticipation of an event much further down the line. It's not like hope that my child will have quality of life for the time that he is living, right? So is there a point at which we get to, yes, there's hope, but is it really not connected to the instance at hand? And I think, that's certainly a concern in this instance. I think I also, the idea you were talking about the importance of really talking about the options down the road is really important. And I think in this kind of a case, it actually offers the opportunity to have the larger discussion about what prognosis is for that child. And so, it is a little bit about asking, I think, the families, well, what are they imagining? What are their goals? What are their hopes in relationship to pursuing fertility preservation? And I think even having that discussion helps understand a little bit about the why, because it could be possible that somebody could at the same time be interested in pursuing fertility preservation, but maybe actually have a pretty good assessment in discussing with you what the prognosis is. Now, those things may not be linked. But having that discussion, I think, helps also understand in that scenario where the family is coming from. And I think it can be important to understand also like how they anticipate, and again, especially with something that's experimental, like how do they envision this being used later on, and how connected is that to what the possibilities really are. I also always think sometimes when we're asking, having these conversations with patients also, how long it's taken all of us to understand the complexities of both prognosis and fertility preservation and what we see as sort of the reality. And so I think always remembering how much this is really linked to what people's hopes are. And sometimes it's sort of a vehicle in a way to sort of explain that. And then of course, I think when I think about, well, what are the risks and benefits? Well, maybe there really are benefits for somebody pursuing this in terms of how they're seeing the situation, and then you're also trying to understand, well, what are the risks in terms of, the patient health? I mean, in this instance, there's a plan for another procedure with anesthesia. Sometimes that comes up as an issue. Are you doing this as a standalone? Are you doing this, as something that's connected, to something else where you're not increasing that risk?
Okay, great. So similarly, we're going to do a quick show of hands, and especially those of you that are part of pediatric fertility preservation programs. If this is a patient in your institution, can you show hands who would have a discussion with this family about fertility preservation in their child? Okay, I see many hands going up as just the discussion. So that would be education and counseling. And if the family decided to proceed with TTC, would that be acceptable in this case? Okay, great. Thank you so much for participating. Okay, we'd like to just open that for discussion. Joe, did you have any other points that you wanted to make at this time?
For those of you who raised your hands, why? And I'm asking because, one of the big themes, I think, of these cases and the presentation is ultimately to what end, right? Are there limits necessarily to what we do for our patients? The quick answer is yes. But when it comes to children, is there a limit to what we do to people that we make decisions for, right?
Yes, please.
Thank you. This is such a great discussion. Oh, let me take this off because people can't understand what I was saying. So I guess it wasn't clear to me in this case whether there's intent to treat with curative intent in this case. Mm-hmm. So the way that we would generally look at something is, a complex problem like this is if there's curative intent that we're going for survival, and we would hope that that child has access to everything, because they could survive. So it's a one, Mm-hmm. If there's not curative intent, then, we wouldn't actually have that discussion with the family. The other things that we would take into account would be, well, what are the risks of the procedure? Is it more than minimal risk? And or if there are significant risks, can they be managed or not? And is there the potential to use the tissue in the future in parenthood? So is there something to do with the tissue that's going to be a problem, or something to do with being able to use that tissue? But we try and separate the decision making in the sense that, while this is experimental, the surgical procedure itself is generally a safe procedure. Mm-hmm. It's done for other reasons. If a child has got the ability to make a decision in adulthood for themselves, then we support that decision for the child to make that decision in adulthood. In terms of, we're fine taking the tissue if there's an intent for cure, and if it's going to be manageable risks, and if there's a chance of using that tissue. And say if it was something controversial like Turner's, well, we would still say that, well, that little Turner's patient will grow up and be an adult one day, and they can assess those medical risks at the time, and there's a long lag phase between collecting the tissue and using the tissue. Mm-hmm. Mm-hmm. So for me, in this case, I wasn't sure if there was intent for cure or not.
I think what's interesting also about the way the issues you've brought up is that the components of this case, I think, are a prognosis. So we actually talked about the sort of like scenarios of the what ifs, right? So in this particular case, we're talking about a poor prognosis, not really having a risk of infertility from the planned treatment, and the treatment itself, the intervention itself, being experimental, and all of those are sort of components. And so, you could put this kind of case together with those issues in very different ways, right? So like a poor prognosis, but a high risk for infertility. Because of course, intent to cure at diagnosis, when we're talking about these things, is always a little bit iffy, because somebody's going to say, well, if the cure rate is 1%, like, why can't my kid be 1 in 100? And then, the other scenario is a good prognosis, but, not having, a risk of infertility, somebody's interested in pursuing it. So I think all of those things are kind of, these kind of different pieces where we sort of think about it and discuss with families.
Thank you. I like the way that Yasmin responded. And in my mind, there was a risk of infertility, and that's why I said yes. But I just wanted to touch on the first point. As a clinician, I do find it frustrating that the oncologist is treating with an intent to cure and giving chemotherapeutic agents that are harmful in addition to being beneficial. But the idea that we would want to preserve someone's fertility is somehow not appropriate. And that's the struggle for me. If it's less than 10%, to your point, that person could be in the percentage that is going to survive. So I think it is important to offer fertility preservation to those patients with a poor prognosis if there is an intent to cure, and they have a risk of infertility, and they want to take that on for their child. They're making the decision to treat their child with toxic agents for survival. They can make the decision to have their child undergo a biopsy or an oophorectomy, which is a standard procedure in itself.
So again, and I think that's one of the what-if scenarios. So in this situation, there isn't toxic chemotherapy that's really used because it's not effective in this disease.
I just wanted to comment from agreeing with Leslie. I've done consults where a patient had a poor prognosis, but then did survive, and then very angry and very upset that this conversation was never had. I've spent hours in rooms with families trying to explain the best I can, but so I do think at least having a conversation to let them know the risks is definitely important. And then I think that shared decision-making model with patient and treating teams really has to be implemented.
Yeah, I think that's important, both Julie and Jen, because really what we're talking about, Joe, is paternal. That would be a situation of provider paternalism to decide whether we were going to offer it or not versus that shared decision-making model, I think.
Yeah, I'm not going to harp on this too much, but I think when it comes to health literacy, medical literacy, and families, and really explaining a lot of this, a great point is just to hit on, well, what's the goal, right? Is it achievable? If it's not, let's reassess what that is. Another big question is, who is this for, right? Who are we doing this for? Or what is the outcome, or what does that look like for an agent? And who is that agent? Usually we like to say it's the patient, but we do a lot of things to children because parents have asked us to do these things, right?
Yeah. Yes, Kyle.
Yeah, so in part, I'm just going to join the choir. I'm not an ethicist, but one of the things that I think, to me, it doesn't make any difference whether it's a poor prognosis or a good prognosis, and the reason is because right now, we don't actually know how many of those patients are actually going to be infertile, how many of them are actually going to come back and use their tissues, and in fact, we're gambling on therapies that don't even exist now, and they may not ever exist. And so for me, the risk, that is the possibility that there would be no benefit related to the fertility, is equally shared on the poor prognosis and the good prognosis. And just to reiterate the point, if we make a decision that somebody doesn't preserve because of a poor prognosis, but then they survive, then they wouldn't have been involved in sharing the decision. Of course they can't, they're too young, and that would have been a decision that was made for them. And I echo exactly what Julie said. Lots of patients, we've all heard them express anger about not having been given the opportunity to preserve their fertility.
So I think again, part of this is so much of putting the pieces together, and I think actually in the pediatric world, we've come to a place where we do believe everybody should have a discussion about this, regardless of any of the other factors that are involved at diagnosis, and that's really, as a field, I think where things are being moved. And because I think we don't know. I just have two thoughts. One is, these are two of my favorite topics to talk about. One is that I think they're really, there still is kind of a conflict a little bit between the world of oncology and the world of reproductive endocrinology to some degree about who's serving the best interests for the patient, when I think it really is a joint sort of work together. And by the same token, I mean, one of the things that I think these situations offer is actually really an opportunity to sit down and talk with families in a way that we don't often talk to them. And that is really such a valuable, intervention to sort of move toward those goals. One of my second favorite topics is, if this was a girl, and we thought there was some, degree of chance that she was going to be, going to live, and her intervention is ovarian tissue cryopreservation, that is a different intervention in terms of potential, reproductive potential later on. So to the best of my biologic understanding, if you take a piece of the testes, you're not really affecting future fertility potential because germ cells themselves can replicate. And so there really isn't a downside to that. But what happens if this was a girl and the option was ovarian tissue cryopreservation and the possibility was to take out an ovary when she has a low risk of infertility and maybe a poor prognosis, but maybe not zero? Have we actually hastened her entry into menopause? And I know everybody always says the data shows that, it only decreases, you only go into menopause 1 year later, but again, we've never looked at people who have an ovary or part of an ovary removed and then get chemotherapy. So I think, that risk-benefit analysis is very different for girls than it is for boys. And I mean, so in almost any situation, I think a testicular tissue biopsy isn't really detrimental once you get past the point of whatever the scenario is for doing it, if that's okay, then that's sort of fine. But I think the discussion is different when you're talking about ovaries. I don't know what the answer is. I don't know what the answer is, but I think that's the point, is nobody does.
Yes.
Hi, I'm Erin from Colorado, and I just want to echo Leslie and Kyle's sentiments that we are kind of building on the concepts of justice and equity and providing these consults for everybody regardless of their risk to fertility, whether it's a poor prognosis or a low risk. We're having these conversations. But my question is that often I don't get, or I should say the family doesn't have time to process the diagnosis before I'm asked to come in to do the fertility preservation consult. So I'm wondering if you have any tips or tricks for counseling with these patients or conducting these consultations when they haven't yet processed the diagnosis and or prognosis.
That's a great question.
I mean, I think the tool that I always used was you've had a lot, put on your plate today. Oftentimes it could be a same day conversation or the next day. and that I kind of use the words that there is no right or wrong answer, and you have to decide, that quality of life and those pieces that are going to be most important to your family, and, those type of things. So that's kind of how I do it, and then have a navigator or a team member follow up, several days later, usually one or two. I know we don't have that much time, but just, are there more questions? There was a lot of understanding, trying to provide as much resources that they can read on, and letting them know we're not pressuring them into this, but we're letting them know it's available if they think it's the right choice for them.
I think another way that I try to phrase things when we're talking about this is I really highlight that the patient or the family is making the best decision that they can make with the information that they have right now. And so I'm always thinking, even in the initial conversation, about, I sort of think of it as trying to manage regret, down the road, is to say, we can talk about this as much as you want. This is the information that we kind of have, and you need to really acknowledge for yourself that the decision for right now makes sense for right now. And if we still have a relationship, later on, where you're questioning what the decisions were at the time, I'll be here also to say, remember, these were the reasons why, this was a good decision. Because I think in so many ways, it's easy and tempting to sort of rewrite history once this is always a scenario where as you go along, you learn so much more about it, and you might feel differently, but you were where you were when you made the decision, and that made it a good decision for your family or for yourself.
Yeah, great. Molly, yes.
So you guys certainly picked a complicated case, but I think even, at least at Michigan, even if you took away the surrogate decision-making, the experimental option, the poor prognosis, if somebody's getting a treatment that is known to not affect their fertility, we don't offer invasive procedures. And that's, whether you're 5 or 20. We offer elective egg retrieval for, people who want future fertility because of not having a partner or that sort of thing. But from a fertility preservation standpoint, if we think someone's fertility is going to be fine at the age of maturity, we probably would not. But the point I actually want to make is that anyone who knows me knows I do a lot with the LGBTQ community and helping them build their families. And we had a huge ethical discussion about this at Michigan, and I just think we need to be careful to say we wouldn't offer it if they were not being treated with intent to cure. Because now change this to a married 30-year-old with metastatic breast cancer. Intent is not to cure. She may live 5 years, and she and her husband want to have a baby with a surrogate or a gestational carrier. And we had to have a very long conversation in our clinic because understandably some of my partners were uncomfortable with that. Like, how am I putting this child into a family where I know their mother is going to die? And I think everyone has the right to decline things. But my stance was I could get hit by a truck tomorrow and my kids would be motherless, 1. 2, if we think a child needs a mother, then are we not going to treat gay men? And conversely, if we think a child needs a father, are we not going to treat single women or lesbians? And so I just think we need to be really careful about who we decide to, give a child to or not based on their prognosis.
Your first point, I think, is great about really non-maleficence, right? We're looking to minimize harm. And I think minimizing harm in these considerations when it comes to retrieval or preservation has to be considered, right? Is this going to be invasive? Is this going to add another layer of recovery or compromising this individual? That should absolutely be weighed into the decision. But to the other piece, right, it's like, oh man, growing up without a mom, it's not like she's unaware that that's a possibility, right? And in that moment, knowing what her prognosis is, knowing what, right, they can make an informed choice with the information they have in front of them. Really quick, effective forecasting. I don't know if anyone's ever heard of this. On a scale of 1 to 5, 1 being no change to your life at all, 5 being a massive change to your life, how would you rank getting a colostomy? 1s, 2s, 5s? What about dialysis? 5s, 10s, right? We're really bad predictors about how we're going to react in that moment. Once we're face-to-face with the situation, we are much better at making those choices because we're in the actual situation itself. That's why advanced care planning gets a little tricky, But to your point, right, in that moment, they make a decision, they have a good idea what the values are, they can see it through. That's an ethically supportable way of going about it.
Yes, Barb.
Oh, thank you. Full disclosure, I work at Lurie, so I may have somehow been involved in discussions around this case. A couple things. I think a DIPG case, as somebody just pointed out, is really extreme because those are the patients that have some of the most dire prognosis. I still struggle with Ewing sarcoma patients when somebody will come and whisper, well, they have about a 20% survival rate, so should we really be doing this? Or they're on Medicaid, so they can't possibly afford all of this. So I think that there can be a lot of ethical discussions in all of this, which make this really hard. My, I guess, rule of thumb is I want to listen to the story. I want to know what's motivating parents to do this. And one of the very first brain tumor cases I ever was asked to consult on, and it was a young man who was going to sperm bank. The dad was like, I want to be a grandparent. That is not the right reason to do this. And we really had to step back, got social work involved, because we all needed to work with his family to make sure that this dad's motivation for his 14-year-old son, who had just come out of the neuro ICU and probably not really capable of making that type of decision, that dad's motivation was that he was acting on behalf of his child and not to preserve his own interest. About once a year, I will have a parent say that to me, and we need to have a conversation with that. So I guess that to me is really one of the most purest tests that I have when I'm asking for families to make decisions about this is what's their motivation, what's their story. And then on the treatment team side is, are you placing judgments on where you think the family lives, how much money they make, who can support them, as well as their prognosis. So it's not an easy decision to make, and we're fortunate that we have multidisciplinary teams, including social work, ethicists, REI, Peds Hemonc, to help us with all of this.
Yeah.
Those are great points. Thanks, Barb.
And I think that money piece, I also just really appreciate bringing that, up because again, it is a huge issue. I do think a lot of people make judgments, prejudgments, or have thoughts about, and in a way, if you ask them, they would say, I'm trying to prevent disappointment, or like they feel like they're doing something good, but I mean, of course, a plug for the next lectures coming up in terms of insurance reform, but I totally agree. I mean, I think when this is a high priority for patients, they can figure it out, or there are other ways, or also there are ways to discuss that, that disappointment with them. It is the way things are. So I really agree with really trying to take away our own thoughts and motivations and really listen to the patients.
I just wanted to make two comments about something you said, Jen. I think part of where the conflict between oncology and reproductive specialists comes in is, I think it feels to us as this is the one place where a physician group is denied access to a population based on what feels like paternalism coming from another group of providers, as if we all don't want what's best for the patient. So I think that's where some of that conflict comes from, and it'd be really great if we can resolve that, because I think, we all want what's best for the patient, and as physicians, we should have the opportunity to speak to a patient that wants to speak to us, right? And then the other comment—
I totally agree with that. I mean, and 100%, and I think all of the recommendations also in the pediatric world, when you talk about where those, patients just wanting to talk to somebody is part of the recommendations.
Right.
That should be a referral.
Right. And then the second comment I would say is, I worry a little bit about saying it's different if it's a female or different if it's a male, and what is the risk. As Molly stated, if it's low risk, male or female, we shouldn't be pursuing these therapies. But if there is a risk, and we've decided as a body what is moderate, what is high, then yes. But male or female, right, if there's no risk, it should be the same kind of.
So I actually don't agree with that. I really think, and I think this is becoming more really more of thinking about how recommendations are, that I just think that males and females are very different in this scenario. And I think that, again, we've really moved to the recommendation that all post-pubertal males should sperm bank before treatment. And that it's an assessment of the risk-benefit analysis and the biology. And it's not the same in females. It's just not the same. And so I think the biggest picture is the same in the sense that we want to achieve something where the risk-benefit makes sense, right? Like that should be the same, whether you're male or female. But that equation is just different because of the options. I think that when we think about sperm banking, I always say, like, in the worst toxicity is that you're 14 years old and you have to sit in a room with your parent and hear somebody say the word masturbation and and then sort of go through it. Somebody offered me another toxicity about actually doing it, but there really aren't downsides to it, right? So in the post-pubertal population, sperm banking it's a different situation. But I think the big picture is this. I think that, again, when we're saying if you get to the same point where the risk-benefit is, but the risk-benefit analysis is different.
I think we've got to wrap up. I'm so sorry for not getting to
It did
everyone's
turn out to be a
questions. I'm
debate,
so
so you didn't
excited
think it
that
was gonna
everyone
be a
asked
debate.
such great questions. And I appreciate everybody. I'm going to quickly just move to the references, and Yasmin is sitting down, but we use this paper that you were part of from Australia when we have some problematic cases for prepubertal patients, and we've had an ethics advisory board member be part of our protocol development through the IRB, and this gives kind of a good table to think about ethical concerns that might be playing a role for prepubertal children and how to kind of think through them and quantify them. And then and some of the things on this list are if the child needs a standalone anesthetic, and some of it addresses prognosis and cost, just how to weigh those things. And then there's kind of a checklist that if you're having multiple conflicts that are kind of arising, that could trigger an ethics consult for that patient. So if there were sort of multiple sort of gray areas that were coming up that made it ethically problematic, we've really liked that paper. And then the other one that I would just point out is this paper from 2016 on testicle biopsy. And this was a study that used the threshold test for providers, parents of boys with childhood cancer, and adult survivors of childhood cancer. And in the study, those patients either did or didn't have fertility preservation. But this table was really interesting to me because throughout their study, their data showed that survivors and parents were willing to accept a higher risk, a higher chance of complications from a procedure. They were willing to pay more, and they thought the acceptable infertility risk was quantifiable or similar to what providers would want, but they were willing to pay more for it and accept more complications. So I think it's just interesting that providers sometimes we have our own bias about what families will or won't accept, and we're not always right. So in summary, we thank you for your participation, and we definitely recommend involving your ethics team if you have challenging cases. Thanks. Thanks so much. Thanks so much.
Which paper I was writing on.